So we have 3 lectures in this. Before we start off the lectures, I would like to say that this session is sponsored by Johnson & Johnson. So Madam Kritika Doshi will take the first lecture, Role in Chronic Pain Management.
Good afternoon, everybody. I would like to thank AORA Scientific Committee for giving me a chance to come and express my thoughts today. From acute pain and anesthesia, we are going to chronic pain. And I'm going to be talking on how, as anesthetists, we can be a part of chronic pain management. I will start by telling that the IASP, which is the International Association for Study of Pain, Task Force on Taxonomy, has said that no clinical or radiological examination can reliably identify the source of pain. So if you are expecting that the CT, MRI or ultrasound will tell us what is the source of pain, that is not possible. And we need methods that allow more precise localization of the source of pain, and that is where high precision nerve blocks come into the picture. As regional anesthetists, you are all very familiar with giving nerve blocks, and as anesthetists, you all are used to dealing with acute pain. Acute pain is, as you all know, a response to an inciting event. On the other hand, chronic pain is not acute pain which persists for a long time. Some acute pain does go on to become chronic, but most chronic pains do not have an acute phase. They are because of some kind of dysfunction in the nervous system, peripheral or central. As anesthetists and regional anesthetists, the advantages that you all have is that you have a good knowledge of local anesthetics, neuraxial blocks, peripheral nerve blocks, good at navigating needles, having the feel of tissues, good at resuscitation, and a good understanding of acute pain. But for chronic pain, there are some disadvantages that we have because it's a completely new subject. It requires different skills. We need to have better clinical skills. We are very poor at patient-oriented talking. We need to have a dedicated time slot when you can sit in your consulting, patient can come and see you, and no emergency cesarean section or trauma case can take you away from there. The guidelines for chronic pain nerve blocks require some kind of imaging. Some speakers have already spoken about it, either fluoroscopy or ultrasound, which are both expensive and time consuming, in addition to having a long learning curve. A major chunk of chronic pain is cancer pain, which again we need to know a lot about in terms of its treatment, the various opiates that we can use, the different formulations of fentanyl and morphine which are available. There is a good article on the various formulations. Due to lack of time, I'm not going into it. There are different conversions that you need to know from oral to transdermal. And again, as I said, when you give nerve blocks, what you are doing is not treating a patient in chronic pain. You are just diagnosing where the pain is coming from. And in addition to that, you are also giving an important break in the pain cycle, when the patient can go on for the corrective treatment. Dr. Bala yesterday showed a very good example of a patient with post-traumatic syndrome who was given a peripheral nerve block for 6 days. With a reduction in the pain score, his actual treatment, which was physiotherapy and rehabilitation, started. So that is how chronic pain management is usually done. If without knowledge we do a procedure, a patient is sent to us by a consultant and we do a procedure, it would be like just aiming in the dark. If you are lucky, you will get a good response. If you are not so lucky, you will not get a good response. And it is not a question of lucky. If your block is not indicated, you will not get a response, even if you do it correctly. And the reason why the speciality of chronic pain has come was because there was something lacking in the understanding of pain traditionally. Something more was needed, and that is why the whole speciality of pain management has come into being. So we need to acquire more knowledge, different skills. And that's how I come to today's topic. As anesthetists, how we can help in chronic pain. First, continuing as anesthetists, the most important function that you all can do is to prevent the patients coming for anesthesia from having chronic pain. Second is when, as an anesthetist, you want to change over and become a chronic pain patient, how you can do, I will talk about it. And the most important function would be to sensitize and make other colleagues and consultants aware of the importance of good pain management in the perioperative period. As anesthetists, it is very important to quantify the pain that the patient is having, because if you don't quantify it, if you do not treat it adequately, there is a lot of evidence which shows that all this is a big risk for development of chronic pain. These are patients who came for elective surgery and they went back with chronic, constant, unrelenting pain. There are certain surgeries which are known to have progression to chronic pain. There is a very good website, prospect guidelines are there, you can look at them. They give guidelines for most of these surgeries, www.postoppain.org. They give guidelines for what is to be done in the pre and peri-operative period, including the post-op PACU. Also, what should not be done is given in the website. There is a good article on when does acute pain become chronic, which are the pains which have a tendency to become chronic, and it also says that when you use multimodal analgesia technique, you can definitely prevent chronic pain. Certain drugs like gabapentin, a lot of speakers have spoken about using gabapentin, are known to prevent the acute pain from progressing to chronic post-surgical pain. Some surgeries and female patients are known to be more susceptible to developing chronic pain. So that is why when you have a female patient coming for any surgery, do not label her as sensitive, having emotional component, or somebody who's catastrophizing her symptoms. Be sensitive to the patient, let her get an extra analgesic dose, whatever is needed. Spinal anesthesia, there is evidence which is showing that spinal anesthesia is beneficial as compared to general anesthesia in prevention of chronic pain. Many drugs, ketamine, a lot of people have spoken about it. There is a lot of evidence that when you add ketamine to your multimodal anesthesia technique, it can prevent progression to chronic pain. This is one of the prospect guidelines for TKR. Thoracotomies, very good talk was there in the morning. So the important thing from all these is that you need to have dynamic pain relief. Background pain can be taken care of with oral analgesics and parenteral analgesics, but for dynamic pain relief, you need to have local anesthesia and regional anesthesia techniques. Let me give you two examples. This first was a patient who was a young male who had fallen from a great height. He had multiple bony fractures. Because he had some vertebral fractures, he was not given any regional anesthesia. The fixation was done under general anesthesia. In the post-op period, in the first 24 hours, patient continued to have pain at a VAS of 100%, despite having good amount of analgesics. On the second post-op day, he refused any kind of injections, any patient coming and touching him, any sister coming and changing the bed sheets also. And this patient had to be taken to the operation theatre, and an epidural had to be placed after giving him general anesthesia for positioning him. Fentanyl propofol was given to position him in the lateral position, and then once the patient was light, under CM guidance, an epidural had to be placed. Another patient, on the other hand, he was a known case of ankylosing spondylitis. He had very severe ankylosing spine. He had very little movement at the hip and knee joint. He had not slept supine for more than 3 months. This is how he was held. You have heard about how the spine was assessed. There were good talks, and he was given spinal plus epidural with very good pain relief, and 6 hours post-operatively physiotherapy could be started. I will come to now how you can progress into chronic pain as an anesthetist. I found one article, there was not many articles on this. In Canada, they did a survey of how many anesthetists are practicing chronic pain. Of the people who responded to this, only 38% of the anesthetists were involved in doing chronic pain work, and of these 38%, only 30% had some kind of training. So most of them did not have any formal training in chronic pain work. And what was the extent of the work? The most common intervention that they did was epidural steroid injections, which I think is present over here also. Many of you must be giving epidural steroid injections. So again I come back that we need nerve blocks for diagnosing where the patient is having pain from. Once you diagnose, then you can do the treatment. The spine, most anesthetists are very used to the spine. You can do difficult spinals and epidurals, and these are some of the chronic pain interventions that you can do in the spine. Epidural steroid injections, you will get a good response if there is an inflammatory component, because the steroids act due to their anti-inflammatory action. If you are giving the steroid for a non-specific back pain, you will not get a good response. So knowing what you are doing is very important before you do the procedure. For anesthesia, we usually go to this posterior epidural space or the interlaminar epidural space, and if there are adhesions in this lateral epidural space, your drug may not go to the site of action, which is near the dorsal root ganglion or around the posterior longitudinal ligament. That is why in chronic pain we do a procedure called as transforaminal epidural steroid injection. But even when you are doing an interlaminar epidural, what you can do is, somebody already mentioned about using a C-arm. Along with the C-arm, inject a dye. That is called an epidurogram. You will then be able to visualize the epidural space. You will see how high or how low your dye is going, and that will tell you where your steroid injection will also go. And this will also tell you whether your steroid has gone to the correct place. Transforaminal epidural steroids are done under live fluoroscopy. This is something that needs to be learned over a period of time. Caudal epidurals everybody does. You have seen the use of ultrasound and nerve stimulators. One more thing that you can add to that is use of C-arm and dye, where you can see the epidural space very well. This is the epidural space, and in the sacrum, this is not, in the sacrum you have ventral sacral foramina. This is the epidural space, and these are the ventral sacral foramina from which the dye escapes, and that is why you need a higher volume in the caudal epidural space. Stellate ganglion is another simple block that any anesthetist can learn to do. Trigger point injections for entrapment neuropathies. This is a patient who had excoriation because of pain, because she was not able to move. An ilioinguinal nerve or a genitofemoral nerve block can be given for such patients. Lumbar sympathetic blocks for CRPS. Femoral nerve blocks can palliate the pain of a pathological fracture of the femur. Upper limb CRPS, somebody mentioned doing a continuous axillary nerve block. So any continuous brachial block can be done if you are not familiar with the stellate ganglion block. But you need to remember that with the blocks you will reduce the pain. But return to function is also needed, which is also part of the treatment of chronic pain. A continuous suprascapular nerve block for frozen shoulders, shoulder arthropathies and post-surgical entrapments. Trigeminal peripheral nerve blocks. So after the intervention, the corrective treatment, which is correct pharmacotherapy, physiotherapy, there are so many other things that need to be done. And that is why what I have been told is to explain that chronic pain is not just doing nerve blocks, it is more than nerve blocks. Nerve blocks are for diagnosis, and the role of the anesthetist in chronic pain is more than interventions. The anesthetist can be the one stop for any patient with chronic pain after having adequate training and knowledge and doing the correct treatment. Thank you.